Hi everyone. I want to go over hypothyroidism versus hyperthyroidism now. And I have this broken down into two columns. Hyperthyroidism is in the first column. Hypothyroidism is in the second column. And the best way to learn these are to just compare and contrast like this in columns. So hyperthyroidism, and then I have thyroid storm. So thyroid storm right here, just right next to that, and you should remember from patho, is a hyperthyroid emergency, meaning when somebody has such high levels of thyroid hormone, it could put them into a hyperthyroid emergency, which we call thyroid storm. Whereas a hypothyroid emergency is called a myxedema coma, and that would be a decrease in thyroid hormones. And when it gets to be so severe and the hormones are so low, they could put them into a severe hypothyroidism, which we refer to as myxedema coma. So let's go ahead and start with hyperthyroidism right here. And the first thing I'll talk about is the causes, etiology. It's more common in women, usually about an 8-to-1 ratio. Actually, both of them are more common in women. And it's because women have stronger immune responses, and hence that makes women more prone to autoimmune disorders. Just in general, that's kind of helpful to know. Estrogen and progesterone may play a role, but regardless of the cause, women are more likely to get autoimmune disorders, and that's what hyperthyroid and hypothyroidism is. So in hyperthyroidism, the body makes like an antibody, and the antibody goes to the thyroid, and then the thyroid just makes too much hormone. The common onset is between the ages of 20 and 40 years old. People can get it later and even earlier, but that's just the most common time that it's diagnosed. Most cases are diagnosed between those ages. Graves' disease is the most common presentation, so go ahead and star that. And Graves' disease is an autoimmune disorder, and it causes the thyroid to make too much thyroid hormone. So it's the most common cause of hyperthyroidism, and that's what you should write there. There's other causes, Graves' disease being number one. Some other causes which are helpful to know is if you remember learning about amiodarone can cause some thyroid problems, and that's why anybody who takes amiodarone does get their thyroid hormones checked, or their T3s and T4s checked at least annually to make sure that the thyroid isn't being affected. The pituitary tumor, and any type of maybe like cancer or something, toxic adenoma. So number one cause, Graves' disease. Basically the second most common reason somebody would present with hyperthyroidism is actually what we're doing is we're over treating hypothyroidism. So somebody has hypothyroidism and we give them medications that increase their thyroid hormone production. We give them too much thyroid hormone and it puts them into a hyperthyroidism. And that's going to be the same when we talk about hypothyroidism and vice versa. So they have to kind of keep them between this spot right here. But commonly number one being Graves' disease. What are some signs and symptoms? So what I want you to think about is I just want you to think about this person who has too much thyroid hormone. And if it's too much thyroid hormone, we're jazzed up, okay? So I have a little picture here that you can kind of take a look at. And the hyperthyroid is actually on the other side than what I'm talking about is right here. And I have it also listed up here. So nervousness, anxiety, increased sweating, right? Just think of just somebody being jazzed up and high anxiety and nervousness, and they're hot and they're sweating. And both of them can be fatigued, emotional liability, because they just have this labile emotions because this hormone is so high. tremors, you know, they could have fine tremors, or just their hands shake. They're just kind of a manifestation of their nervousness and anxiety. Deep tendon reflexes are hyperflexia. This is all increased, fast type of symptoms. Increased appetite. They always want to eat. They always want to eat, but they lose weight. They're skinny because they're just burning calories because their metabolic rate is super high. Their GI tract, they have loose stools, they can have diarrhea, they can have hyperactive bowel sounds. So these aren't, try not to just memorize these, just try to make sense of these and you'll always remember them. They tend to have like a smooth, warm, kind of a smooth skin, like a velvety skin, whereas a hypothyroidism, they tend to have more of like dry skin and brittle nails. Somebody once told me that they learned it this way, and it kind of stuck in my mind, but the smooth, warm, velvety skin, they think of a little bunny rabbit, and bunnies are really fast and hepped up and stuff. And so they have this warm, velvety skin versus the opposite for hypothyroidism. Thin, fine hair. Here's one right here, very important to know, exophthalmos. And exophthalmos is those big kind of bulging eyes. And what happens is that antibody that is produced goes to the thyroid, remember, and it makes too much hormone, and it goes to the eyes and kind of like causes inflammation in the eyes. And they get these big eyes. They look like their eyes are wide open and kind of popping out of their head. They have high heart rates, high blood pressure. So often this is how they present to the ER, they present to their healthcare providers. They have palpitations and a high heart rate because, again, they have an increased metabolic rate. Heat intolerance, so they're always warm, they're always sweaty, and they're always hot, and they always have fans going, and increased incidence of atrial fib. This goes along with the tachycardia. There are others, but these are kind of, you get the gist of this, right? So let's take a look at this person right down here. So think of it, like if I were doing the drawing this picture, I would have made this like a really skinny person. So they're kind of skinny, and she's sweating. She's got those big eyes. See how puffy her eyes are, and her eyes are kind of bulging. They have that look. This says weight loss or weight gain. I just noticed that, but it's weight loss. They have weight loss, whereas you'll see hypothyroidism. They're slow and sluggish. They have a weight gain. Heat intolerance, racing heart, diarrhea, muscle weakness, nervous anxiety. So all these kind of things you can kind of add to this. Take a look at the picture and make sure you know the symptoms and just the group of symptoms that go with that. Okay. So laboratory testing and diagnoses. So this right here is something else that's important for you guys to know. So this is always on like standardized testing. So we take a look at their hormones, and we want to know what either their thyroid hormones and what they're going to actually look like when we draw their blood. So let me just go back down to this picture right here and just do this little review with you. So as far as the thyroid axis, we have the hypothalamus, which sends a signal to the anterior pituitary gland, okay? And the pituitary gland sends this hormone called the thyroid stimulating hormone, or TSH. It sends this TSH to the thyroid gland, and basically this red arrow here, this thyroid stimulating hormone, comes to the thyroid gland and tells the thyroid, hey, we need some more thyroid hormones. So the thyroid gland, okay, and it secretes T3 and T4, and it circulates around the body, and with growth and development and increased catecholamine effect with all that, metabolic rate. And then hopefully it's in a normal range, and then we just have normal metabolism. All right, and then what happens is we have this negative feedback system. So as this is being secreted, the pituitary gland says, oh, look, there's plenty of T3 and T4 circulating in the blood, so I don't need to secrete TSH anymore. So it doesn't. But when this T3 and T4 gets used up and it's not circulating, this negative feedback process tells the anterior pituitary, says, hey, wait a minute, there isn't any T3 and T4 because it's been used up. So that's that gland's signal to go ahead and secrete the TSH to the thyroid gland again, and hence we get T3, T4, and this process goes on, and this is normal, okay? So let's take a look up here, hyperthyroidism, trying to make sense of this. When somebody has a low TSH, they have that's one of the laboratory diagnostics of hyperthyroidism, and an increased T3, T4. So think about hyperthyroidism right here. Okay, so this hyperthyroid, it's this big swollen gland and it's overactive, right? So it's secreting T3, T4. It's over secreting because remember that antibody makes that thyroid make too much T3 and T4. So there's a lot of T3 and T4 in the bloodstream. So the pituitary gland says, gosh, I don't need to secrete TSH because there's plenty of T3 and T4 in the bloodstream. So hence TSH is decreased, T3 and T4 is increased in hyperthyroidism. Make sense of it, know it. Like I said, this is a great standardized question test. You'll all see that on my exam and on certification exams. Serum ANA can be elevated without evidence of them having any type of lupus or any other collagen disease. So sometimes that could be increased. Thyroid radioactive iodine uptake and scan is usually performed to establish the etiology of hyperthyroidism. So what happens is we give somebody iodine, and the thyroid loves to suck up iodine. That's when we eat iodine, the iodine gets absorbed through the thyroid, and that's how T3 and T4 is actually made. So to do a scan to be able to look at the thyroid, they can give them some radioactive iodine. They give them iodine with radioactivity in it, and it circulates in the blood, and the thyroid sucks it up because it wants to absorb this iodine, and then hence they can scan and they can see the person's thyroid. Okay, so management, you should know the medications from, well, I don't know. Let's see, you probably haven't taken pharmacology, but these are called thiourea drugs, and it's important for you to know that these are the medications, the methimazole or the tapazole, you don't need to know any doses, is a medication that's given for hyperthyroidism, and this propylthiouracil or PTU is another medication that is given for hyperthyroidism to decrease that overactivity in the thyroid. Radioactive iodine, again, we can use the radioactive iodine to scan and take a look at the thyroid. And it's also, if the medication doesn't work, it's also a treatment. We put iodine in their body, and the radioactivity, it's in a pill, and it goes to the thyroid, and it kind of kills cells in the thyroid, and hence that hyperactive, overactive thyroid will slow down. If that doesn't work, they go to thyroid surgery, and sometimes they'll get a part of their thyroid removed or all of their thyroid removed, and then they'll have to take some thyroid replacement therapy for the rest of their life. This Lugol solution is just a solution if they're going to go to thyroid surgery. This is something that you should at least be able to recognize the name of. They take this orally daily for 10 days before their surgery, and what that does is it kind of shrinks up the vascularity of the gland, so it doesn't make it so vascular and make it bleeding, decreases the bleeding for surgery. Another thing it's important to know is propranolol is the medication of choice for symptomatic relief, basically for the tachycardia or atrial fib. And propranolol or Inderal is a beta blocker, OLOL, and it's not cardioselective, meaning that it just is useful for all the beta receptors in the body. When there's catecholamine that tries to attach to it, it'll block it. So hence, it's not just for the heart, it's for all the beta receptors. And that's why it's the beta blocker of choice for symptomatic relief for somebody with hyperthyroidism. And avoid aspirin, basically, especially in hyperthyroidism or thyroid storm, because it can lead to some decreased protein binding. And with that being said, with that decrease in protein binding, that could cause T3 and T4 to elevate. So that's something that we generally want to teach the patient. Okay, so once you learn hyperthyroidism, hypothyroidism is going to be easy. You've essentially learned that as well. So let's go ahead and go over that. So it's primary disease of the thyroid gland, and it's a deficiency in thyroid stimulating hormone. Pituitary deficiency in thyroid stimulating hormone can be a cause of it. Iodine deficiency can be a cause of it, but the number one cause of hypothyroidism is Hashimoto's thyroiditis. Okay, so that's important to know. And again, I know you've learned all this in patho, so hopefully this is just a review for you. So Hashimoto's is an autoimmune disorder, and what happens is it causes the thyroid to just kind of, if you think about it, just kind of shrivel up and not work very well. There are other causes, and some damage to the gland can cause it too. Anything that just would interfere with the actual thyroid gland not working. Just this isn't big and fat and secreting all the T3 and T4. Now it's shriveled up and barely working, and it's not secreting any T3 and T4 anymore in hypothyroidism. Symptoms, just the opposite of what we said: weakness, fatigue, arthralgias, cold intolerance. They're always cold, constipation, hypoactive bowel sounds, sluggishness, weight gain, dry skin, hair loss, brittle nails, bradycardia, a deep tendon reflexes are slowed. So pretty much everything the opposite of hyperthyroidism. You could take a look at this picture right here. Again, cold intolerance, constipation, weight gain. They just have trouble. They just can't lose any weight because they have no metabolic rate. This right here says irregular and heavy periods. They both have issues with their menstruation, so whether it's hypo or hyperthyroidism. And then let's take a look at the lab. It's the opposite of hyperthyroidism. So now if you think about it, the TSH is elevated, and the T3, which really isn't as accurate as the T4, but you can just know that T3 and T4 are low. And what's happening now is, think about this thyroid gland being small and shrunk up, and it's not secreting any T3 and T4. It just doesn't have the ability to secrete the thyroid hormones anymore. So the pituitary is saying, oh gosh, there's no T3 and T4, so it keeps secreting the TSH, and that is going to be increased. And this right here, the TSH, is really one of the most helpful lab values that you'll see. So it's kind of the opposite. Hyperthyroidism has a low TSH, and hypo has a high TSH, but it makes sense if you think about it. And again, you know the medication, the levothyroxine or the Synthroid, they take that every single day. Generally, about 30 minutes before breakfast. We always want to instruct them to take that first thing in the morning, because it's going to increase their metabolic rate, and they can have the positive effects through the day. So that's hypo and hyperthyroidism, and that's it. Thank you.